Good afternoon, everyone. My name is Julie Wong. I am the Senior Manager of Education and Community Programs at the Alzheimer's Society of Toronto. I wanted to welcome you to our webinar today, which is a collaboration between the University Health Network Memory Care as well as AST to bring you a variety of caregiver education topics related to dementia. A few housekeeping pieces before we begin. I have placed everyone on mute just so that we can hear better. This session is being recorded so that the video will be available on both the UHN Memory Clinic website as well as the Alzheimer's Society of Toronto's YouTube channel. So that will be available, I would say, a few days after today, just to make sure that we remove anything or do some post editing as needed. There will be an opportunity for questions, but if you have any, please feel free to enter them into the chat. Please feel free to enter them onto the chat so that we can ask. And I do ask that you stay on mute throughout the whole until the end of the session. So today I would like to introduce you to our speaker today. Our speaker is Dr. Melissa Lee. And Dr. Melissa Lee had completed her medical school training at the University of Toronto. Sorry about that. At the University of Toronto and Family Medicine residency at Western University prior to completion of her palliative care fellowship at the University of Toronto. She joined Toronto Western Hospital as a staff palliative care physician in 2019, where she works as an inpatient palliative care consultant and in collaboration with a memory clinic as an outpatient palliative care physician. She's a clinician, teacher, and lecturer at the University of Toronto for palliative care and palliative care residency program assessment lead. She has a strong interest in building capacity for palliative care in the non-malignant population, particularly within the outpatient setting. Her academic interests are in medical education and quality of improvement. Please join me in welcoming Dr. Melissa Lee. The floor is all yours.
Great. Thanks so much, Julie, for the warm introduction. And thank you so much to the invitation by the Alzheimer's Society and UHN to give this talk today for a topic that's really near and dear to my heart. And I'm hoping to spend the next hour talking a bit about the role of palliative care in dementia. And I want to just thank Julie ahead of time for helping to navigate the technical aspects of this presentation. I myself have no personal conflicts of interest. So what I'm really hoping for is by the end of the hour, we'll be able to go over the role of palliative care in advanced dementia, address some of the common myths out there about palliative care, as well as provide an overview of medical assistance in dying and the role that it may play in dementia. So I first actually just wanted to get a sense of who's here in the audience. So I was wondering if you could share with us if you're here today because you're caring for a loved one with dementia, if you work in healthcare, or just as a general public.
Hi, everyone. My name is Aida. I'm a clinical counselor, psychotherapist as well, working with COSTI, family and mental health. So I'm work in mental health field. That's why I'm very interesting to know more about dementia and how it affects the client's well-being. Thank you so much.
Great, wonderful. Thank you for joining.
So the poll right now, I have a poll, depending on how you're joining us, you may or may not be able to see the poll. Right now, based on who we have, the majority of who's here with us do work in healthcare, but we do have a few that are caring for a loved one with dementia. So the bulk is healthcare workers.
Great. Okay, it's good to know. So the first thing I actually wanted to share was this phenomenal book that has been out in the media, and you might have heard of it. It's a book that was written by Dr. Atwal Gawande. I highly recommend it. He is a revered surgeon, writer, Rhodes Scholar, and Harvard professor, and he's written a multitude of novels. But this one he wrote based on his experience with his father being diagnosed with advanced terminal cancer. And it was through that lens in which he gained a very different perspective on going through the healthcare system as a family member caring for a loved one versus as a doctor. And it was through that much more humanistic lens in which he wrote this book. And I think a lot of the issues and topics that he speaks about here resonates with all of us, but particularly with those of us who have cared for loved ones living with advanced illness. And I want to just paraphrase from an interview that he gave. He said, I interviewed more than 200 families about their experiences with aging, frailty, and serious illness. I met and interviewed scores of palliative care clinicians, and what emerged were a group of people who did know what to do in these situations when faced with an unfixable problem. So, as a surgeon, he spoke about his experiences where he was used to fixing problems. But when his father got diagnosed with incurable advanced cancer, he couldn't fix it. And what emerged was a very different experience for him. When we can't fix things, what else can we do? And how do we help people live with best quality of life? And this is really what this book is all about. He says that the two main things I learned is number one, in medicine and society, we have failed to recognize that people have priorities to serve besides just living longer. And this resonates a lot with me through my medical training. I think so much of our focus is on diagnosis, workup, and fixing things. It wasn't until further along in my fellowships and residency, particularly through my palliative care experiences, where I learned about other ways that we can help people. And he says, number two, the most reliable way to learn about people's priorities is to ask, and we don't ask. And I think this is something that, as a palliative care clinician, I feel very passionate about is the importance about having these difficult conversations and teaching other healthcare providers and clinicians how to ask these difficult questions in order to provide better care with use of evidence-based framework to do so. So the second poll I wanted to get a sense of from the audience is, have you had experience with palliative care in the past? Are you familiar with the term advanced care planning, or previously talked to friends or families about what you would want or hope for if you were ever critically ill? If you've had these conversations before, have you ever shared these thoughts with your doctors or healthcare providers?
And these are all pulled up in front of you. So the four questions are lined up one after the other. So as you scroll down, you will be able to see the other three questions that were asked. Give you a few more moments for everyone to answer, and then I'll share those results. So of those who have answered, 89% have had experience with palliative care. 89% also familiar with the term advanced care planning. A little bit lower, 67% have spoken to their family friends for what they would hope for if they were critically ill, nearing the end of life. And of everyone who answered, 100% have not shared these wishes with their doctors.
Okay, great. So thanks so much for everyone's participation. I'm glad that there is familiarity with, you know, technology of palliative care, and interesting that, 100% have not shared with their primary care team. So I want to talk a little bit about the role palliative care has played in the dementia population. I think, in comparison to other disease sites such as cancer, unfortunately, palliative care has played a much smaller role in dementia. And I think that's for several reasons, some of which being that, unlike a cancer diagnosis, dementia is not often recognized as a terminal disease, even though we all know that unfortunately it is. So there's often this misperception that we don't really need to talk about these things. In terms of prognostication, there's a lot of uncertainty, and people can live with dementia for several years, up to decades at a time. And so it becomes very difficult to predict when people move from mild to moderate stages towards advanced and end stages of dementia. So it's challenging to really know when is appropriate to introduce palliative care. And there's been minimal research done as well in the dementia population in regards to when is best and how do we best integrate palliative care. So, what is palliative care? Palliative care is a medical specialty where we get involved with any patients with serious illness. We often work with your other healthcare providers as an interdisciplinary added layer of support, and we focus mainly on one of two things. We assist with management of any illness-related symptoms. So, whether that's physical symptoms like pain, shortness of breath, confusion, emotional and psychological aspects of the illness experience. And we can also be helpful with decisions about future healthcare going forward. So, starting conversations about what is most important, what are your hopes and values to ensure that the care you receive is actually congruent with what you would want. And I do want to highlight that, the involvement of palliative care is not based on a patient's prognosis. It can be appropriate at any age and at any stage in a serious illness. A lot of times I hear palliative care may only be appropriate if someone is in the last days to weeks of life. And though this is certainly a part of what we do, we really can be involved in a patient's care at any point of their disease trajectory, including when they're on disease modifying therapies or active treatment. So really our involvement is based on needs, not based on prognosis. And we know that there's a lot of evidence that demonstrates the benefits of palliative care to lead to improvements in quality of life and decreasing symptom burden by about 66%, and that these improvements can last for months after initial consultation with the palliative care team. And maybe most importantly is that there is high levels of satisfaction and positive patient experiences from people who have engaged with palliative care teams. And 93% of people who receive palliative care are likely to recommend it to others. I wanted to highlight this article to really, demonstrate that the public seems to be demanding a better care model for patients living with advanced disease. This was a piece that was written by a daughter who is a caregiver for her father with advanced illness and trying to navigate the healthcare system and honor his wishes to die at home. And I will, highlight that it generated over 1,000 comments, and that just shows how much it resonates with the general public, with a lot of us, that when we have an acute issue, we have a healthcare system right now that is there for us and actually knows how to fix these acute problems. But unfortunately, when we have chronic progressive disease that spans over years, our needs often far surpass what our current healthcare facilities can provide. And it highlights the need to really consider a systems change. So this quote, I think, highlights well the crux of the problem. While it can seem like a miracle of modern medicine that fewer people pass away from sudden heart attacks or acute illness, we are facing the perverse and tragic alternative. We slowly and painfully get sicker and sicker, pump our bodies with more medications, spend increasing amounts of time in hospitals and nursing homes, and ultimately die with little dignity and perhaps lots of regret. And so I think this highlights the fact that people want an alternative. And I believe that palliative care is one of the ways that we can help these people and drive system change. My hopes is that with time, there's increasing comfort with terms like palliative care, and that there are certain myths I hear on a day-to-day basis in my clinical practice that I believe do contribute to palliative care being something to be feared or cause people to have an adverse reaction to. So I just want to spend some time addressing some of these common myths. So the first myth is that dementia is not a terminal illness. And we know that unfortunately this isn't true. We hear a lot about heart failure and lung failure. Dementia essentially is brain failure. And we know it's progressive and that there's no cure. And because the brain is the central control station for the body, when it doesn't work, there are many complications that can follow. What we often see in the last years of life are recurrent infections, whether that's in the skin, in the lungs causing pneumonia, or in the urine, and increasing progressive problems with eating. People start needing help and assistance with self-feeding, but also because the brain is responsible for that very intrinsic coordination of our esophagus, which is the tube that goes from the mouth into the stomach to make sure that we actually swallow food and liquids safely. It doesn't go back into our lungs. When dementia progresses, we start seeing progressive problems with coordination of that reflux. And so I do want to talk a little bit about the dementia illness trajectory and just to orient us on this graph. From left to right across the x-axis is time, and from top to bottom is on the y-axis is someone's function. So at the time of diagnosis of dementia, we already know that there's already been impairment of someone's day-to-day activities, whether that's to do with mobility, cognition. And even though certainly there is unpredictability and uncertainty between every individual who has a unique trajectory, broadly speaking, what we know with progressive dementia is that there is gradual decline and worsening of function over time. And along the way, we see these bumps in the graph, which represents, complications. You may have been admitted to hospital with a pneumonia, received treatment, stabilize. But what we often see is that people do not recover to a prior baseline, and then they're often in a new baseline of reduced function. And that pattern continues until their natural end of life. And this red graph that I've depicted here is to show when typically palliative care is introduced in someone's care team. And we can see that it's quite far into the illness trajectory and close to end of life. And our hope is that not to say all patients need a palliative care physician per se involved in their care earlier on in their trajectory, but that conversations about the palliative care approach are started by the healthcare team much, much earlier than that red arrow depicts on the graph. So advanced dementia is really the several years after diagnosis, and the typical features of this stage are people have very minimal ability for speech and language with profound memory deficits at that point. The level of independence and ability to provide basic self-care is significantly reduced. And I'd say that for every disease, prognosis is hard to predict, but particularly in dementia, it's very challenging to predict prognosis. I hear all the time from patients and families that this worry that their loved one will suffer at the end of life. And I can say that from what we see, there are not typically big surprises at end of life for people living with dementia. So I don't see lots of complex pain or symptoms that we have to manage. Most of the time, we just see the common end of life symptoms that we see from all comers of disease. So most patients will be sleeping most of the day, morning and night. You will start noticing mouth secretions, and that just comes from a collection of saliva because of the impairment in swallowing that we see in advanced dementia. Pain is not typically a common symptom that we see at end of life in dementia. And there may be some mild shortness of breath if people are prone to aspirations or some restlessness and agitation. But all of these symptoms can be very well managed with our typical approach to pain and symptom management end of life. So myth number 2 is that, palliative care is only for people who are close to end of life or those with cancer. So I hear this consistently where I get asked to get involved in a hospital in a patient's care. And as soon as I introduce myself as a palliative care clinician, there's this reaction of, surprise, fear, because in the general public, it's associated with only end of life care. So we've touched on this, but I really want to emphasize here that palliative care is about quality of life, not death. And this quote I want to read out by Dr. Balfour Mott, who was one of the founding fathers of palliative care. What has surprised me is how little palliative care has to do with death. The death part is almost irrelevant. Our focus isn't on dying. Our focus is on quality of life. And I think if you speak to any of us who practice palliative care, this captures really well the essence of our work that we do, is that it's really focused on how we can help people live well and live well now, despite a serious diagnosis. And the death piece is a small component of what we do. Of course, it's something that we address, that we talk about what to expect and how we may manage different scenarios as someone approaches their end of life. But the rest is all about living and how do we live now with best quality of life. And so I want to just, speak to this graph below that depicts another care model of how palliative care can work with your other healthcare providers. And what we see here on this graph is that we can be involved even from day one of diagnosis of an advanced serious illness. And we often work in conjunction with your other healthcare providers. And it's not either or. A lot of our patients are still receiving disease-directed therapies, and we are also involved. And there may be points in someone's illness trajectory where most of the care, for example, is driven by your neurology team. And we have a very small role and we're just in the background. And then when things start changing inevitably later on in the disease trajectory, we may actually start playing a much bigger role. So it really is a bit of a partnership between the rest of your care providers. And the reason why we think this model works, so there was a landmark study that was done out of Mass General Hospital in Boston that looked at the early benefits of palliative care. And though this was done in a cancer population, we've seen, emerging data since that's been consistent, confirming that these benefits are also applicable to a non-cancer population like dementia. So essentially what they did was they divided 151 patients who were diagnosed with incurable lung cancer into two groups. The first group received what was standard of care with the oncology team. And then the second group received all of that. So the standard care through the interdisciplinary oncology team, but also concurrent palliative care. And what they found from the study was that early palliative care involvement was associated with increased quality of life, decreased symptoms of depression, decrease aggressive care. And what that means is, less chemotherapy or invasive therapies in the last months of life. And what was actually surprising, I think, even to us palliative care clinicians, was that in the group that received palliative care concurrently, they actually were shown to live longer by a couple of months. So this was a big moment for our discipline because it was high quality evidence that really demonstrated the benefits of early palliative care involvement for both patients and families. And I think one of the main reasons people are hesitant to bring up palliative care or have their loved one be referred to a palliative care provider is because of the belief that talking about these difficult things will cause their loved one to lose hope, to get depressed, and possibly die sooner. And now we have evidence that's been consistently replicated since to show that this is not the case. People do not lose hope. They actually have lower levels of depression. And we've seen that consistently in other studies that have been published since, is that when people are given the forum to actually express what their fears are, to ask questions about what to expect, they have lower rates of anxiety and depression because they can then prepare. And actually, it may help them live longer. So the third myth, I hear this on a routine basis, not only from patients and families, but also from clinicians and healthcare providers that may not be as familiar with prescribing opioids, is that opioid medications hasten death. So we know that opioids are our best treatments for treating pain and shortness of breath when other treatment options no longer work. So this alludes to opioids like morphine, hydromorphone, oxycodone. And what often is a worry is that people who are on these medications will hallucinate, get confused, stop breathing, and that it hastens death. But we know that when opioids are prescribed appropriately, this does not happen. And the only side effect really that is consistent is constipation, which is easily treated. What we see typically is that people actually are able to carry about their day-to-day, enjoy their life, and get to do their daily functions because they're no longer as bothered by uncomfortable, bothersome symptoms. Myth number 4 is that palliative care only happens in hospitals. So we know that palliative care can occur in a variety of settings. We have home palliative care teams that are either run by nurses or physicians that can actually come into a patient's home to provide palliative care. Palliative care is certainly offered in the vast majority of hospitals. There are outpatient palliative care clinics, but there's also palliative care supports that are available in rehab facilities, long-term care. And if you do have more complex needs at the end of life, then you may be admitted to a specialized unit like a palliative care unit or hospice that are staffed by palliative care physicians. Myth number 5 is that not eating will cause a patient to starve to death. So what we know with dementia is that as the disease progresses over time, decreased intake of food and water with eventual, cessation of all eating and drinking is actually expected and is a natural part of the disease. A common fear I hear is the fact that, my loved one is starving or dying of thirst. And we know that actually from the literature, there is no discomfort that is associated with this natural progression of decline in their intake. So it does not cause the body any harm. And oftentimes I find that the patient themselves have very little interest in eating and drinking. They don't have much appetite. And a lot of times it's more of a concern from the family. Myth number 6 is that tube feeding will help a patient live longer with dementia. So we know from a lot of the evidence that's come out is that unfortunately artificial feeding by tube, so giving feeds through a nasogastric tube that goes in the nose and goes down into the stomach, or through a gastric tube that feeds directly into the stomach from outside the skin, actually does not extend survival in patients with advanced dementia. It does not prevent aspiration events. People are still at high risk for aspirations where food and water go down the wrong tube into the lungs instead of into the stomach. And it does not lead to weight gain. So even if you continue to be artificially fed, you will continue to lose weight as dementia progresses. And it's very risky. It can cause pain, infection. It often worsens confusion and agitation. People come in and out of hospital because the tube gets blocked or the tube gets pulled out. And we often see that even in hospital, people have to be restrained in order to keep patients from pulling out their tubes. It can lead to a lot of distress, and leading organizations recommend against tube feeding for patients with advanced dementia. So ultimately, what we've seen is that palliative care may improve end of life. It can lead to less hospitalizations in the last year of life, better symptom control, caregivers feeling more prepared, and leading to more people actually dying in their setting of choice. And I think the reason why this is because our focus really is on matching treatment to patient priorities. And a lot of the work we do is trying to assess what your priorities of care are. What would be important to you at this time? What would be important to you or your loved one if X, Y, or Z were to happen? And I think our main goal is to listen and understand what the patient is hoping for, wanting, to share information about what to expect as their disease progresses over time, and to essentially make recommendations to ensure that the care received is congruent with what their hopes and wishes are. I think a lot of the times, there needs to be some education about what therapies can and cannot do. Oftentimes, very aggressive therapies don't do what patients and families are hoping and can cause more harm than benefit. So I think it's just so important to have these conversations about, what really are the indications, benefits, and risks of medical interventions that may be offered. So if there is one takeaway from this presentation, I hope it's this, is the importance of advanced care planning and starting these conversations with, your family, your loved ones, and your healthcare team. And I want to also, pinpoint that this is not the same as looking at a list of things and deciding, I want this or that in regards to medical interventions, because without the clinical context, it's not very meaningful or useful to do this exercise. I think this alludes to a much broader conversation that's meant to be iterative over time. We often recommend that we start these conversations before crisis or before problems start to arise, because it's very hard to plan when things are changing very fast and there's lots of emotions involved. And really the focus is on trying to establish, certain value systems that may guide decision making in the future, because we can't anticipate what scenarios may arise, but at least starting these conversations will help us determine what framework can guide decision making in the future. So what advanced care planning is really the process of considering, discussing, and planning for future healthcare in the event that you are incapable of consenting to treatment yourself. And so an important piece of this is also thinking about who you would want to be your substitute decision maker in the case that you are no longer able to speak to your doctors or your healthcare teams about future healthcare decisions. So I do want to highlight Speak Up campaign, which is a national campaign and I think a wonderful resource about advanced care planning conversations. There's specific material for each province. It's available in multiple languages. I think it's an excellent resource that can be accessed by patients, families, and healthcare providers online. Because these are difficult, sensitive topics, there are guides that you can go through with loved ones on here. With families or healthcare teams. And so it's a wonderful resource that I just want to highlight here. And then if I can ask Julie to perhaps play the video about advanced care planning from the Speak Up campaign, just to give us a bit of a context of what they do.
Absolutely. If you can just cue me that the sound is working fine. I know we tested it before, but it's always tricky.
I would guess there's a big percentage of people don't like to talk about it. And there's a big percentage of people that it happens suddenly, you never get a chance to talk about it.
Well, of course, we are from the age that things weren't talked about.
It's not part of, hey, what'd you have for supper last night?
You've got to know what to do, what you want done.
We have to talk about this. We should talk about it so that when and if this happens, you get the care that you want.
Great, thank you, Julie. So the next part of the talk, I just want to spend giving a bit of an overview about medical assistance in dying and its role in dementia. So first, I want to acknowledge that this is a controversial and sensitive topic, and it remains so as well for many healthcare professionals. And this portion of the talk is really meant to provide a general overview for information purposes and to share recent updates in the legislation that may affect the dementia population. So as we all know, in 2016, there was passing of Bill C-14, which legalized medical assistance in dying. And what this was really alluding to is circumstances where a medical practitioner, so a clinician, or a nurse practitioner at an individual's request may administer a substance that causes an individual's death. So this was previously referred to as euthanasia and now is referred to as provider administered MAID, or prescribes a substance for an individual to self-administer to cause their own death. And this is now referred to as self-administered MAID. To be eligible for MAID in Canada, a person must be eligible for publicly funded health services in Canada. So this is to prevent international tourism for medical assistance in dying, be at least 18 years old and have the capacity to make a decision about MAID, make a voluntary request that is not the result of external pressure, be able to provide informed consent, as well as be diagnosed with what legally in the law is considered a grievous and irremediable condition. So whenever I hear patients share with me a desire to die statement or a MAID request, I think the first and foremost that to me is a sign that they have great suffering. And so ultimately, one of the main roles that we have as clinicians is to help relieve suffering. And even though a desire to die statement may represent a request for hastened death, in many cases, I find that it represents a great expression of distress without literal intent to die. And so I think it's just so important as well for us to remember that it's essential to explore what this request means to the person, where it's coming from. I think it can reflect a multitude of factors. Often it can reflect a response to possibly unmanaged symptoms, whether that's physical, psychological, or spiritual suffering. It can allude to a loss of sense of self, a fear of dying, a desire to live, but perhaps not in this way, and oftentimes just a loss of control over one's life. And so I think exploring this statement involves a dialogue that aims to appreciate, the physical elements of someone's suffering. Is there any unmanaged symptoms, the social elements of their suffering? Often I hear feelings of shame, isolation, that they're a burden to their family, any emotional factors, fear, anxiety, depression, as well as existential factors. Oftentimes, this leads to a feeling of hopelessness or lack of meaning and purpose in the setting of being diagnosed with a serious progressive illness. So, the importance of really discussing and addressing their fears, concerns, and unmet needs. What is the process for accessing MAID in Canada? So the request for MAID can be verbal or written. It must be done in the presence of one independent witness, and you do have to undergo legally 2 independent assessments by either a physician or a nurse practitioner to determine eligibility. And it's really through those clinician assessments where you're determined if you're eligible for one of 2 tracks, which I'll explain a bit later. Whether you're eligible for track 1, which is reasonable, foreseeable, natural death, or eligible for track 2, which is the non-reasonable, foreseeable, and natural death. You must be able to give informed consent to receive MAID after being informed of all the other means to relieve suffering. So you do need to be offered referral to relevant disciplines. Often that includes palliative care, spiritual care, mental health, disability services, so that you are aware of the other means that are available to alleviate your suffering. And you must be given the opportunity to withdraw consent to the procedure immediately before the procedure. And so that, implies that you need to be able to provide express consent to MAID the day of the procedure. And the only exception to this is the final consent waiver that is only available through track 1. So in March 2021, there was the passing of Bill C7, which actually introduced 2 tracks that you can be eligible for in Canada. It removed the requirement for death to be reasonably foreseeable. So the first track is the reasonable, foreseeable, natural death tract, which actually by law does not require a specific prognosis. However, in order to be eligible for this track, there has to be sufficient temporal proximity to death or an expected trajectory towards death that is fairly predictable from your combination of known medical conditions and potential sequelae. And so only in this tract is if you are deemed to be at risk of loss of capacity prior to the procedure, you may actually sign a waiver of final consent. And this allows the MAID provider to actually still deliver the procedure on the day of that was previously scheduled or before, if it's felt that you are at risk of losing capacity. So I will say that you're only eligible to sign this waiver of final consent if you are approved for track 1. So you still need to meet all the eligibility criteria, which states that you have a reasonable foreseeable death and that you are capable at the time of MAID assessments as well as scheduling the initial day of the procedure to actually consent to MAID. So this precludes a lot of our dementia population. Track 2 is the non-reasonable, foreseeable, natural death tract. So this is when they've removed that criteria where you may be diagnosed with a disease, for example, like ALS, where we know that there's a predictable trajectory towards death, that people with ALS can live for several years. And so there's no need to be eminently dying or have the requirement for your death to be reasonably foreseeable. There have been some extra procedural safeguards that have been put in place in this tract because of this. So you have to have a minimum 90-day waiting period between, getting assessed and approved in order to proceed with the procedure. And this is to ensure that your request for MAID is consistent, and only if you are at risk for losing capacity in that time could that waiting period be shortened. And there is the requirement that one of the two assessors must have expertise in the condition causing suffering. So for example, if it's ALS, one of your assessors has to be a neurologist. And as with the other tracks, you do have to be offered and informed of other available supports and services that can help relieve your suffering. So, some of the challenges that have occurred with medical assistant dying and dementia, from the beginning, there's always been more requests than clinicians can meet. And so accessibility to medical assistants in dying still remains a problem. And on top of that, depending on where you are and perhaps where you're admitted, there are certain religious, institutional, conscientious objections that make made inaccessible for patients who are admitted to certain facilities. In Ontario, you can self-refer as well as have a physician refer, but that's not required to the Provincial MAID Coordination Service. And this is a community that's been put in place to help facilitate access for patients to actually access assessments and provisions across Ontario. And various hospital systems and teams have worked out, different ways that they can provide MAID assessments and provisions depending on where your care may be. I think one of the challenges with dementia is trying to time the intersection between, still maintaining capacity, but being at a point where someone feels that their suffering is at so severe in their disease course that they actually may want to pursue something like medical assistance in dying. And so I think there, with the law right now, because advance requests for MAID are not permitted under law, this precludes a lot of our dementia population where by the time their disease is so severe and their function has been so compromised with such low quality of life, their dementia is very, very advanced and they may have lost capacity to actually access MAID assessments and certainly get approved for procedure years before that. However, I think there's a lot of changes that are coming up with the legislation, particularly in Canada. There's certain talks right now that are happening in Quebec, and I think it's going to roll out shortly. And I imagine in later 2024 up into 2025, we're going to receive a lot more confirmation from the outcomes of some of these legal proceedings as to where this may fall with the dementia population, because advance requests are certainly being something that's under review currently within the courts, given the immense amount of public pressure that has come forth over the years to amend the law to really allow requests for MAID before all eligibility criteria have been met. So that concludes my presentation. These are my references. And now I want to just open the floor to any questions.